Hello, good morning, and welcome to 100% Optical Online, and the first of our webinars on today's CT program, which is brought to you in partnership with the AOP. I'm Ian Beasley, Head of Education for the AOP, and I'll be hosting today's webinar, while Molly's on hand to answer any technical questions that you might have. Just a few housekeeping points before we get started. So the presentation will run for about 45 minutes or so, and then we'll have plenty of time at the end reserved for any questions. There's one interactive CT point associated with this webinar, and that will be uploaded in the next 10 working days. It is worth stressing that you need to attend for the duration of the session to be eligible for the CT point. And if you can use the chat function at the bottom of your screen to submit any questions, we'll try and answer as many as we can within the time frame, but we may not be able to get to them all, of course. So let's begin. I'm delighted to welcome my colleagues from the AOP. We've got Clinical Director, Dr. Peter Hampson, and Head of Clinical Negligence, Eva Schmidt. And together they'll present case examples from the AOP on intracranial tumours and how to spot the red flag signs and symptoms. They'll also discuss the considerations around ongoing support for patients and the implication this has on the cost of these cases from a civil perspective. So in the first instance, I think we're handing over to Aoife.
Thank you, Ian. Good morning, everyone, and welcome to 100% Optical. Thank you for joining us in what is the first presentation of the day. I am a solicitor here at the AOP, and I'm also the head of clinical negligence. I oversee all clinical negligence claims, whether that is a multi-million-pound case that's in litigation and proceeding to trial, or if it's speaking to a member who is worried about a patient complaint. I'm joined this morning by Peter, and he will be the main presenter this morning with a really interesting and informative presentation focusing on tumours. But first of all, I'm going to give a very short presentation with an overview of some of the legal aspects in a clinical negligence claim, with a particular focus on tumours and why they can be so challenging from a legal perspective. The most common claims that we continue to see are a failure to spot retinal detachments, glaucoma, incorrect prescriptions, and what we're here to discuss in further detail today, brain tumours. I would say that tumours represent approximately 20% of the claims that we see. Tumours are also some of the most complex cases and can also take many years to reach a conclusion for reasons that we're going on to discuss. We are also seeing an increase in tumours in children, and this is significant because unlike claims in adults, where the time for bringing a claim is 3 years from the date of the injury or knowledge, whereas the clock doesn't start ticking for the time that a claim can be brought until they turn 18. So if you saw a child, you may not even know about a potential claim for many years to come, or if you have been made aware, it could take many years to reach a conclusion. So in the event that something during your day-to-day work goes wrong, what standard are you as an optometrist being judged by? Sometimes we can be confused into thinking that we're being judged by a higher standard than we really are. But in actual fact, you're not being judged against the best of the best or a specialist in a particular condition. You are judged as a competent optometrist acting in everyday practice. So simply translated, you are expected to act in a way that is both reasonable and in a way that the majority of other optometrists would. So a patient makes an allegation against you, or worse still, you receive a formal letter from a solicitor informing you that a patient is seeking compensation in respect of an examination that you did. And that's scary, right? So in order for a claim to be successful, what needs to be established and, of course, proved? Now, it must be remembered that it is for the claimant to make their case. Firstly, and this is fairly straightforward, and for your purposes, you will owe a duty to your patient and that you would be conducting any patient examinations with reasonable care. Secondly, there has to be a breach in that duty of care. Now, that can either be something that you did do or something that you didn't do. Now, typically, we see this in respect of a failure to adequately examine a patient, a failure to refer a patient that may lead to a delay in diagnosis. This is specifically relevant to tumours, and Peter will come on to some of the red flags that would mandate a referral. However, it isn't enough. The claimant has to also establish that the breach was the cause of the injury that was sustained. And this is really important, and it's called causation. Now, as I mentioned earlier, we are seeing an increasing number of tumour claims, and these are significant because they can be incredibly complicated in respect of causation. Typically, the claimant has been seen by many different practitioners over many years. Therefore, it's really important and necessary that we investigate every appointment that the claimant has had, GP visits, visits to A&E, consultants they may have seen at the hospital, and that's in addition to optometrists and ophthalmology appointments. What we find can also be very difficult to digest is why, when a claimant has been seen by so many different experts, that the responsibility for the misdiagnosis can be solely targeted on one appointment with one optometrist. Also, what's really interesting is that despite the successful removal of a tumour, the delay in diagnosis can lead to severe neurological and psychological injury. Now, this is why tumours can incur significant sums of money in the form of special damages. Therefore, in order to determine who is responsible, this requires a plethora of experts that need to come on board and assess the extent of the injuries and produce evidence as to who is responsible for the breach and to what extent each missed opportunity has caused the claimant's injuries. To give you some idea of the range of experts that can be involved, we would need a neurosurgeon to comment on the tumour itself and the details surrounding the removal of the tumour, and of course, the prognosis. Neuropsychologists to comment on any potential learning and thinking differences, neuropsychiatrists to comment on the alleged psychiatric disorders, neurologists to comment on any problems caused to the nervous system. This is in addition to the experts in ophthalmology. So I think what's interesting here is that when you think that we deal with the eyes, this actually isn't, because there may be no ongoing problems with the eyes at all. And what may have started life as an optom appointment to where it leads can be very different. And in defending claims of its nature involves a multidisciplinary set of highly specialised consultants, which have to be brought together separately in the first instance to build a defence and rebut the claimant's allegations. However, it doesn't stop there, because investigations into the condition and prognosis will need to be undertaken, because if the claimant establishes breach and causation, they could be entitled to all their losses flowing as a result of the injury, and looking to recover can potentially be huge sums of money, running into millions of pounds. This is due to the fact that in some cases, they will require care for the rest of their lives and for damages for the loss of any potential income for the rest of their lives. I'm now going to hand over to Peter, who's going to look at some of the subtle complexities in clinical presentations of potential tumours. Thank you. And of course, I'm happy to answer any questions that you may have at the end. Peter, over to you.
Thanks, Aoife. Hello, everybody. So I'm going to run through 3 cases, and then we're going to have a look at some of the red flags. And then we're going to come back to the cases again. And in between, we're going to do a bit of learning. I've got a number of polls scattered throughout these cases. So you will have to interact, and I've got those running on a separate screen, so I'll be able to check that you're all paying attention as well. So let's get on with the cases. So the first one is a 45-year-old female patient who presented with some headaches. Pretty much all else was normal, There was a low to moderate plus prescription found. Visual acuity was good. Examination was generally normal. IOP was 19 right and left. There was some visual field loss, but the optometrist thought that that visual field loss was an artifact and didn't make a referral. So we're going to go into an early poll just to get you into the swing of things. And please try and answer this without second guessing based on the title. So we've told you this is a tumours lecture. It's probably not that hard to put the pieces together of what went on, but what would you have actually done? So if we pop poll question 1 up on the screen, or make poll question 1 live, please. What would you have done next? Would you have done nothing at all? Would you have repeated those fields? Would you have referred routinely? Or would you have referred urgently? And I'm going to watch the poll and just see as the answers start to come in. Okay, and we've got a couple coming in. At the moment, it's fairly evenly spread. Okay, and now it's leapt ahead now. So at the moment, we've got repeat fields is a clear favourite at 88% of the answers so far. 9% would have referred urgently. 2% would have referred routinely. A couple of percent would have done nothing at all. But repeat fields is far and away the leader at the moment. I'll just give it a moment or two more because there's still a few coming in. Yeah, and it's still 85% repeat fields. Oh, the polls will stay open, so we'll be able to just check back on them and see what's going on. So in this case, this patient was diagnosed with a meningioma. So those of you that repeated fields, I think that's a good choice. Those of you that referred urgently, I think that's probably also a decent choice as well. Even a routine referral isn't terrible. Doing nothing, probably a bit more difficult. Let's go to the next case. So for case 2, this is a 12-year-old female patient presented with what are described as migraine-type headaches. They'd seen the GP who'd provided some medications, although the patient is still getting the headaches. Examination was, again, fairly normal. Fields are clear this time. There was a little latent hyperopia on retinoscopy, but the visual acuity was normal. So we're going to go to the second poll, and it's exactly the same as before, slightly different answers granted. What would you have done? So would you have done nothing at all? Would you write to the GP? Would you refer? Or would you have done some extra tests? And again, we'll just give it a second for those to come in. Refers leapt up here. I'm wondering if that's being skewed by the first one and you're all getting slightly nervous. So 67% of you would have referred at the moment. 33% would have written to the GP about the headaches. Nobody would have done either of the other things. So nobody's doing extra tests and nobody's ignoring it, which is good. We'll just let some more answers come in. Oh, now it's swung massively as some more have come in. So now lots of you would have written to the GP about the headaches. It's about 59% currently. Referrals, 17%. Some would have done extra tests, which is interesting. And some of you were quite happy that there wasn't an awful lot going on, which is reasonable as well at this point. We'll just give it a little bit longer. There's a little bit of a lag on the system as they come through to me, so that's okay. And it stayed about the same. We've got a lot more votes in there, but still most of you are writing to the GP, and about 59%. So 59% of you writing to the GP about the headaches. So as I said, probably no surprise here. A few weeks later, this patient is diagnosed with a brain tumor. It's broadly in the clues in the title. Let's go on to case 3. So in case 3, this is a 38-year-old male patient, and he's been getting headaches for some weeks, bit of double vision. There's a small prescription, but acuity is good. Examination, again, pretty normal. There's a small esophoria that's found. And then he comes back a few weeks later, and that esophoria is now breaking down to an esotropia, and the double vision is worse. In fact, it's pretty much constant. And in this case, the optom refers for a BV assessment. So the last poll for a little bit, and then we'll get on to some content a bit more. Poll question 3. What would you have done this time? Would you have referred for the BV problem as the optom did? Would you have referred for investigation routinely? Would you have referred urgently? Or would you have done nothing at all? So we'll open that poll up and just have a look and see what you would have been doing. Okay, we're getting one or two starting to come through now. And a sudden rush. So 81% of you so far are referring urgently. 10% would have done what this Optom did so far and referred for the BV problem. 9% referred for investigation to work out what's going on. We're still waiting on a few votes coming in. We've got a few so far, but there's still quite a few to come. So we'll just give it a little longer still. Okay, and it's swung a little bit more to referring for the BV problem, but still a lot of you are referring urgently. You're obviously a bit concerned. Okay, so this patient was seen in orthoptics, and the squint had increased in size from the point of referral, and they were referred to an ophthalmologist because the orthoptist was understandably concerned. And then the ophthalmologist colleague found advanced papilloedema and thought we need an MRI in this case, so they arranged that. And then this patient was also diagnosed with a meningioma. So, brain tumours. Let's start with a little recap. So there are two main subcategories of tumour. There are benign, non-cancerous, and malignant, which are cancerous. And if a tumour originates within the brain, it's classed as a primary brain tumour. And if it originates elsewhere, it's called a secondary brain tumour. And they're broadly split equally between those two categories, primary and secondary. Generally, benign tumours are slow growing and they don't spread. Malignant tumours tend to grow much more quickly and they can spread and often do spread. All pose a serious risk to the patient though, because there's very little spare space within the skull, and space-occupying lesions, even those that aren't cancerous, can cause serious harm and lead to some of the things Aoife was talking about before with ongoing issues for the patient. So I want to briefly just touch on prevalence and incidence. So prevalence tells us how many people have the disease at a specific point, and incidence tells us how many new cases there are in a given time period. And you might be thinking, well, why does that matter to us? Well, it helps to tell us how likely a patient is to have disease and provides context around risk. Now, the worldwide prevalence of brain tumours is around 77 to 222 per 100,000. It does vary by country, and the incidence of brain tumours is around 11 per 100,000. Now, of course, some of those with the disease will already know, and they will tell you in their history. They may say they're under the hospital and they're being monitored. They may tell you that they're undergoing treatment. But regardless of which figure you go with, whether you look at prevalence or incidence of brain tumours, thankfully they are quite rare, although obviously the impact can be devastating. And this is part of the reason that clinicians, not just optometrists, GPs and all sorts, struggle to diagnose brain tumours, because features such as headache and problems with cognition, changes in personality, are also commonly seen in other conditions such as migraine, anxiety, depression, stress, and dementia. So, for example, the World Health Organization estimates that at least 50% of adults have had a symptomatic headache at least once within the last year. 50 to 75% of those aged 18 to 65 have had a headache in the last year, and 30% of this group report migraines. Up to 4%, or 4 per 100, of the world's adult population have headaches on 15 or more days every month. But as we just saw, brain tumours are far rarer than this. So when we compare how common headaches are and how rare brain tumours are, it's little wonder that they are hard to diagnose. Now, most people will be familiar, probably from university, maybe from other lectures, with the saying, when you hear hoofbeats, think horses, not zebras. Or to put it another way, common things are common and rare things are rare. However, it's important to remember that do exist. After all, they aren't unicorns. So how do we spot the red flags that spell danger and balance the age-old problem of the risk of missing something with the pressure that we're all under of not over-referring? Well, according to NICE, general cancer guidelines give 4 presentations of brain tumours that require urgent referral. And those are those with progressive neurological deficit, late onset seizures, i.e. those not starting in childhood, so they haven't always had epilepsy, they've suddenly developed seizures, headache plus cognitive or behavioural change, headache with papilloedema. And I will come to this in a second, but I think I should point out that the college guidance is very clear that papilloedema is an emergency referral, and I think that's an appropriate position as well. Now, the NICE guidance does go on to say that neurological deficit needs an MRI within 2 weeks, and clarifies that papilloedema may be a late presentation. And this can mean that the tumour might be substantial in size, or at the very least blocking cerebrospinal fluid. And as such, papilloedema is an emergency referral. NICE also say that a history of headaches should be evaluated for red flag symptoms. So with that in mind, let's focus on headaches for a moment, and we'll get to some more polls shortly. So what are the red flag symptoms for headaches? I think most of us are taught the sort of LOFC approach, or at least something very similar to it. And this isn't unique to headaches, but it applies to most reported problems when taking a history in optometry. And I think while this is a good approach generally, it isn't tailored to spotting the red flags for headaches, especially those caused by tumours, although obviously you can use it to get that information. So what are the red flag symptoms in children? In children, we can see that according to NICE, there are a number of red flags, not all of which are specific to tumours, as they're aimed to catch presentations such as meningitis and secondary issues following head trauma as well. Headaches that wake the patient or that they're or are there on waking is a red flag. Headaches that are getting worse, that are progressive. Headaches triggered by coughing or sneezing, fever, vomiting, ataxia, or a change in consciousness, all red flags. And hopefully you will be familiar with most of these. But I think one of interest is sunsetting, and it's unlikely you'll see this in practice, but just in case, I think it's worth raising awareness of it. Sunsetting is when in younger children with raised intracranial pressure, there is a failure of the ability to elevate the eyes, and they resemble a setting sun. So if we look at this fairly simple diagram, we can see that the normal eye position when looking straight ahead, and then underneath we can see that in raised intracranial pressure and that failure of elevation, I don't think it's hard to imagine the iris and the pupil as a sun setting on the horizon, hence the name. Now, when we look at the red flag symptoms of headaches in adults, we can see that there is significant overlap. Again, there are some symptoms that relate to other serious conditions such as temporal arteritis or secondary to cancer or diseases that compromise the immune system. But there is an emerging theme around the important questions to ask. One of those is around neurological deficit, and we've mentioned this a couple of times. So what do we mean by neurological deficit? Well, if we look at this image from the brain tumour charity, and some of you may have seen this in another presentation, we can see that depending upon the location of the tumour, then the effects can be wide-ranging. From the frontal lobe affecting personality, emotions and behaviour, the parietal lobe affecting coordination and face recognition, the temporal lobe affecting hearing and memory, and of course the occipital lobe affecting sight and how we understand what we see. Brainstem tumours tend to be more obvious with their sort of systemic effects, including effects on breathing and heart rate, swallowing. And I think we'd all hope that these would be caught by our GP colleagues, but again, it's just worth being aware of them just in case for some reason they end up sat in front of you. So when asking patients questions about headaches, and where I think LOFC can have its weakness, is that if we follow it too rigidly, patients can fail to understand what we're trying to get at. We know exactly what we're asking, but a sort of very rigid interpretation of where is the headache, how often do you get the headache can be a little bit difficult for patients sometimes. So these are some examples of alternative ways to ask the red flag questions for tumours. They aren't intended to be a catch-all. You have to ask some other questions around headaches as well, but they do show the sort of questions we can ask patients in plain language they can understand. So we have questions around waking and posture to capture the effects of raised intracranial pressure. So does it wake you? Is it there on waking? We have questions around postural change as well. So because cerebrospinal fluid can more easily enter or build up in the head as posture changes, or at least it can be more difficult for it to drain away. So asking them about bending forwards is also important. Sneezing and coughing, and that's for a similar reason, that forced exertion can cause a spike in intracranial pressure. Vomiting with a headache is unusual and is a red flag, unless there is a specific cause such as hangover. And we're all fairly aware of how often patients like to throw in that sort of quip, along with the one about flashing lights only when the police are chasing them as well. Is it getting worse captures the progression of the disease, and the behaviour and personality changes are captured and relate to the slide that we've just looked at on the effects that you may see with tumours. Similarly, coordination and balance, and you're sort of broadly asking those to the patient. But with the behavioural changes, if they've come with it, if it's a child, if they've come with a parent, you may be asking the parent, or if they're elderly and they've come with a child this time, or with a spouse or a partner, you may be asking them if anything's changed, and they may be able to tip you off to that as well. So you can start putting the pieces of the puzzle together. So let's have a look at papilloedema for a moment, because this is another one of the signs that you may see. And first, a little pedantry. So papilloedema is exclusively used when optic disc swelling is secondary to raised intracranial pressure. It's a bilateral condition, but it may be asymmetric. And it differs from other causes of disc swelling, some of which I've listed here, although this isn't an exhaustive list. Ischemic optic neuropathies are normally unilateral, but they still require an emergency referral due to the imminent risks of sight. And one of the things I think that worries most optometrists is, how do we separate papilloedema from other causes of disc swelling? And in honesty, it isn't necessarily an easy thing to do. So let's just have a look at how it's graded. So papilloedema is graded using something called the Frisson scale, and that has stages from 0 to 5 to indicate severity. And while a written scale is all well and good, a pictorial representation is normally far easier. So this is a pictorial representation of each stage, and we're going to have a look at each of these images in a little bit more detail. So stage 0 is a normal optic disc. This is what we're used to seeing. This is what we see all day, every day. Nothing to get excited about realistically. When we get to stage 1, we've got a C-shaped halo that's subtle and sort of grey in colour with a gap in the temporal region. It does obscure the underlying retinal details, and it can disrupt, or does disrupt, the normal radial nerve fibre layer arrangement. The temporal disc margin is normal in a stage 1 disease, though, or stage 1 swelling. When we get to stage 2, that's become a circumferential halo, and we've now got elevation of the nasal border, so that will be the first border to raise. But we can see that we can actually still see the major blood vessels. They're not obscured. We can see them leaving the disc. Then when we get to stage 3, we've got obscuration of greater than 1 segment of major blood vessels leaving the disc, circumferential halo. All of the borders are now elevated by stage 3. And the halo, sort of the irregular outer fringe, has a finger-like sort of, I suppose you could say, dendritic, almost sort of outreaching from it. You can just sort of make that out on the image, depending on the size of the screen. You can see that there's this sort of fingers just poking out, particularly sort of if you look at the sort of bottom right of the image a little bit more around the disc, you can sort of spot it there. By stage 4, we've got a segment of the major blood vessel on the disc that can't be seen. Elevation of the whole nerve head, including the cup. Border obscuration is now complete. We can't really tell where the borders are anymore. And we've got a complete halo. And then by stage 5, you pretty much can't see any vessels on the disc at all, or where they're leaving the disc. And hopefully this one is pretty obvious, and we're not going to miss this one with a little bit of luck, but it's quite a scary thing to see, I think. So determining early papilloedema from normal and non-serious conditions is where most people become concerned. Although even more advanced disease isn't always obvious, and working out which are Distruson can be incredibly difficult. And that's why I think you need to exercise a low tolerance for risk, as the implications of being wrong are significant. When we consider things such as ischemic optic neuropathies, as I said, they are an emergency referral. So that makes it a little bit easier. If you're torn between, is this an ischemic optic neuropathy and is it papilloedema, they need to be at that hospital quite quickly anyway. So that makes the decision making a bit easier. But if you're thinking, is this nothing at all? Is it just Distruson? Those are the ones we're trying to separate out. But the presentation of Distruson is actually quite variable, and it's really not easy always to discern pathological causes from routine Distruson. So we're going to have a little look at that now, and we'll put an example up. So on the screen now, I have 2 images, and one of them is papilloedema. So we're going to make poll question 4 live, I think, now. And I'm just going to give you a moment. Which one do you think is papilloedema out of these 2? Okay, so lots of you have gone for B at the moment. We've only got a few votes in though, so I'm just going to give you a little longer to wait for those votes to come in. So it's broadly 3/4 of you are going for B at the moment, and 1/4 of you are going for A at the moment. So I'm just going to give you a few moments more just to make your choices. It's narrowing a bit now, so people are balancing up a bit. So it's now much closer now. 40% A and 60% B. Let's just see how many votes we get on the other ones. I'll just give you a little bit longer just to get your votes in before I tell you the answer, and then we'll move on to another example in a second. Okay, and now it's evened up a little bit more. So 41% A, 59% B. And I think that highlights that I don't think that's a particularly easy one to tell apart. Interestingly, the correct answer is A in this case. That was the one with papilloedema. So I'm going to go to another one. And we're going to ask basically the same question in a second. So this time we've got 2 images. Same as before, which one of these is papilloedema? So we'll make poll question 5 live and just see which one of these you think is papilloedema. And on the other one, by the way, the other image was Distruson, just to sort of fill in that little blank. But I think you probably all worked that out anyway. Okay, and we've got some poll results coming in now. So far A's leading, 68% A, 32% B, so roughly 2/3 to a third. Okay, we'll just let a few more come in. We're getting around to the 300 odd votes normally. I've got about 57 at the moment, so there'll be a few more to come in. I've got a lot more now, 257. So A, 70% of you think A, and 30% of you think B. I'll just wait for the final refresh and then I'll tell you the answer. Okay, we're about 300 votes there. So it stayed about 70% A, 30% B. The correct answer on this one is B. So really not easy to tell them apart. So as we can see, some of these presentations really are difficult to separate. So and at points, I think we're too keen to blame ourselves for this. So the simple fact is, it isn't always easy. If you don't see lots of these, it isn't necessarily easy. And when you're worried about being wrong and the implications of being wrong, obviously that's not an easy call to make. So OCT can help make that decision a little bit easier, but even that isn't a simple fix. And in the next few slides, we'll see why. This image is taken from a paper that looked at exactly that problem. How do you tell papilloedema apart from Distruson? And these 3 images all show Distruson. The left-hand one is probably the easiest. You've got surface drusen visible on ophthalmoscopy and on OCT. You can sort of, it conforms to the typical lumpy, bumpy appearance that you will have heard talked about in lots of places. And then as the Distruson get more buried, the lumpy, bumpy sign starts to lose value quite quickly. So the middle shows a few visible drusen, and then the right-hand image shows buried Distruson. So you're probably thinking, well, it's easy then, isn't it? We just use OCT. Well, not quite. So we're going to have another poll now, and this is poll number 6. So if we take a look at these 4 images here, I'm going to tell you only one of them is papilloedema. So if we can pop poll question 6 up on the screen, which one of these do you think is papilloedema? And I will tell you what the others are in a moment as well, but we've got another poll after this one. So which one of these do you think is papilloedema? Okay, so we've got some early results coming in. My percentages have gone slightly crazy, but the bar is definitely bigger for D at the moment. So we'll just let a few more come through. This is where if we were in person, I'd be taking sort of random spot prizes and throwing chocolates at you all in the audience, but I'm afraid that's quite difficult by the medium of Zoom. Okay, so D is winning with 68% of the votes. A has got 5% of the votes. B 13 and C 14%. We'll just give it a little bit longer for some more to come in, but D's looking like a clear favourite at the moment. Yeah, and D's still well out in front by 2/3 of you. So the correct answer is D in this case. So here are a few more. And this is the last poll. Then you won't have to keep interacting with me. Well, hopefully you will, but you won't have to keep answering polls after this one. So in this case, we've got 4 more images, but this time there is more than one that is papilledema. So you should be able to select multiple options with a little bit of luck. So we're going to put poll question 7 up on the screen, and I want you to pick all of them that you think are papilledema. So it doesn't mean they all are, but pick if there is more than one definitely on that screen. So please pick. I'll always wait for those to come through. Okay, so we should start seeing some votes through in a second. There we go. Okay, so I feel like I'm doing Eurovision here with all these polls. So the first one, E, 14% of you think E is papilledema. 13% of you think F is papilledema. 34% of you are going for G. 39% of you are going for H. Okay. So we're at about 80 votes or so at the moment. So again, we'll just give you a little bit longer to get a few more in, because I say we're averaging about 300 or so per poll. Oh, there we go, up to 200 now. E and F still lagging behind. G and H still clear favourites. So that's interesting. I'm going to move on and tell you that the correct answer is all of them are actually papilledema, which I think is a little bit scary. And these images are taken from a study on differential diagnosis of elevated optic discs using OCT. So for interest, A was an obliquely inserted or tilted disc. B is a crowded disc, so a small disc densely packed in. C does show buried Distruson. It does look a bit lumpy bumpy. And then D to H are all confirmed papilledema. I think most would probably agree that E could be confused with C. It looks a bit lumpy bumpy, and I'd imagine that's where many of you were going, thinking, well, it looks a bit lumpy bumpy, it's probably Distruson, but they are actually all confirmed papilledema. So yeah, it's not easy, as I say. Now, so what can you use to help you determine papilledema from Distruson? Now, this table, it's a bit busy for a slide. Hopefully you can see it okay, but I'm going to talk to it a little bit. And it's from a paper by Fiona Costello and colleagues, who've done some excellent work on this topic. And there are a number of papers out there, well worth a read. I'll expand on some of the key features in subsequent slides, but let's just run through them to begin with. So we've got retinal nerve fiber layer thickness. Now, this can be helpful in adults, and we're talking on OCT, obviously, at this point. So it can be helpful in adults, not so much in children. And even then, you have to be careful about coexisting pathology. But in adults, retinal nerve fiber layer is thickened in 90% of cases with papilledema. So if you've got an adult patient and you're trying to work out whether it's papilledema or not, that could be a helpful sort of guide for you. Ganglion cell inner plexiform layer thickness can't be relied on. And from the work that's been done, it looks like that is due to some challenges with OCT algorithms. It could be normal in Distruson, it could be normal in papilledema. Bruch's membrane layer deformation. Now I'm going to come to this one on a subsequent slide. Basically, if you see it, it can help to confirm papilledema. But if you don't see it, just because it isn't deformed, that doesn't rule papilledema out. And therefore, seeing it can be a helpful confirmation, but not seeing it isn't necessarily helpful. Scleral canal size has been suggested. That varies too much to be diagnostic. Retinal and choroidal folds. Now, I think this one is very helpful. You shouldn't see these in optic Distruson, they're rare. So unless there is another pathology coexistent which has caused the folds, so such as anterior ischemic optic neuropathy, then if you see them, it's probably indicating something is wrong. And again, we'll come to that in a second. Enhanced depth imaging. Now, and this includes swept source OCT. So this isn't so much a feature of the scan as a feature of the equipment. And basically, the better you can visualize the optic nerve, the easier it is to either see the drusen directly or to look for changes in Brooks, obviously with the caveat I've just mentioned. And I'm not saying you need to rush out and buy your OCT, but as technology improves, this is just becoming sort of more and more normal, and it potentially makes things easier. So it's more really a case of if you've got an older OCT, or just being aware of the limitations of it and that you might not be able to see things. Peripapillary hyperreflective ovoid mass-like structures, or FOMS, and I've never been so glad for an acronym. These are non-specific markers of axonal congestion. You can't use them to discern between papilloedema and optic Distruson. Originally, it was thought that FOMS were a form of Distruson, but we now know that isn't correct. And they don't represent a precursor to Distruson either. They may be seen with Distruson, and they may be seen in other conditions, including papilloedema. Hyperreflective lines, and I'll explain a little bit more on this in a second as well. These are often seen in optic Distruson, but not necessarily in all eyes with optic Distruson. So as such, these lines can't be definitely used to differentiate. OCT angiography, currently being studied. The outcome's not 100% clear. And I think probably these are the most helpful features to use. But a positive Brooks membrane bowing, which I haven't highlighted, I think is also really helpful if seen. So raised intracranial pressure is a well-known cause of chorioretinal folds near to the optic nerve head. And they're also referred to as Patton's lines, which you'll have heard again in talks. And they indicate the areas being exposed to compressive or tensile stress. Although they're not always present, if we see them, we should be concerned. Even more so if we've got other signs as well. So if we've got, the discus looks a little bit swollen, or there are other symptoms such as headaches, such as, neurological function and all sorts. And these images on the screen now are all examples of retinal and choroidal folds. We can see that they can vary, but they're all abnormal. All of these are examples from patients who have been diagnosed with idiopathic intracranial hypertension. So not tumours in this case, but still the same thing. The intracranial pressure is raised, and therefore you can get similar things if you've got a tumour in the brain or anything like that. So that's causing a raised intracranial pressure. So very useful sign to look out for. And then this is an example of the difference between an older OCT with lower resolution and more modern equipment. So these are confirmed optic Distruson, and we can see that they autofluoresce. And we shouldn't forget that if you've got autofluorescence as an option, you can see the Distruson are autofluorescing on the image. That can help you out as well. B shows the sort of limited detail you get at greater depth. And then in C, we can see there is actually a large drusen when we've got, or a large Distruson when we've got that additional scan depth. So we can actually visualize it. And that's what I'm talking about when I say about actually having that ability to more accurately visualize the disc can be incredibly useful. In B, we can't really be certain what's going on there, but in C, we can see it far more clearly. And then if we look back at Brooks membrane bowing, many of you will have seen this image as it's featured again in recent presentations throughout there. It's actually from Fiona Costello's work though. And although it isn't always present, we can see on this image what we mean by the bowing of Brooks. So again, presuming you can get this level of detail on the scan, but if we look at A, we can see the red arrows show that Brooks has bowed upwards. We can see it's physically bowed. And then if we look at B, it's the same eye. We can see that once the intracranial pressure has gone, Brooks membrane has dropped back to normal. And now it looks flat. So seeing that is a really good sign. And the image on the left is what you would see if the intracranial pressure is raised, and B is when that intracranial pressure isn't raised. So they say it's not always present, but if it's there, you've got to be questioning why, and it's another piece in the jigsaw. So this image shows a number of features that I mentioned on that very busy slide, and we can see that there's a peripapillary hyperreflective ovoid-like mass, or FOM, and that's on the center left of the image. It's marked and highlighted. On the center right of the image, we can see the hyperreflective lines or bands, and they're adjacent, or in this case, beneath a large distruson, and the hyperreflective margin of the distruson as well, surrounding a hyporeflective core where the signal isn't getting in. Isolated hyperreflective bands had been suggested as maybe they're signs of distruson, but there's actually something called the Optic Distruson Studies Consortium, and they've said that actually at the moment they don't think they are, or they're not certain, so they don't think, unless you see that associated sort of void that we've got that is indicative of probably a distruson, that just the bands on their own that are marked as with the white arrows as HRB, you can't rely on those. Now, a number of you are probably thinking, hold on a minute, he hasn't talked about lazy V, why haven't you mentioned it? And that's correct. And that's because there's a bit of a debate about its relevance. So there's a suggestion that it's actually a phenomenon, again, of older OCT and poor scan penetration, and also suggestions that it's a poor differentiator. There's a couple of pieces of work here I've cited, one of them actually questioning that, does lazy V exist? Is it just an artifact effectively? And then the other one, which is only from a poster, granted, so not of the same level of evidence, but somebody did a study or a sort of a brief analysis of, gave some clinicians sort of segmented scans of which one is which, and they weren't particularly good, even well-trained clinicians, at using it to differentiate. So first of all, does it exist? And secondly, how easy is it to use? So I think basically from OCT, there is no single feature that's going to exclude papilloedema. There isn't a magic bullet. There isn't a, well, if I see this, then it's definitely not, or it definitely is. You've got to put the pieces together. And it's got to be used in conjunction with good clinical decision-making and looking at all the additional tests. And remembering as well that you may need additional tests that you can't do in optometric practice. So that might be a lumbar puncture, it might be cranial imaging. I think that's enough on papilloedema for now. So we're going to move on briefly to visual fields. So brief revision only. We aren't going to go into lots of detail on this, but there are a couple of important points to remember. So this lovely diagram is courtesy of Sam Strong from Aston University, and it serves as a reminder of the path that the nerve fibers from each eye take and how that distribution of fibers changes as they transition from the eye to the visual cortex. Visual field loss in one eye is prechiasmal, as the fibers have not rearranged significantly at that point. Visual field loss that occurs in the same half of the visual field we call homonymous, but loss in opposite sides of the visual field we call heteronymous. And heteronymous visual field loss occurs from chiasmal lesions usually, so things like your pituitary tumors and those sort of things. Homonymous lesions must be post-chiasmal, and we can use that type of visual field loss to localize where in the visual pathway a lesion or a tumor may be. We refer to the term congruity to describe how similar the visual field loss is between the two eyes. And the more similar they are, the greater the degree of congruity, then it implies that a lesion is located further back in the visual pathway. And we can see that from the slides of sort of picking out where they are. Bilateral chiasmal or post-chiasmal visual field loss isn't limited to tumors and can be caused by ischemic events such as stroke or trauma. They still need investigating and most likely still need cranial imaging. So now a little on BV. Again, a little revision. So first thing to remember is that any sudden onset squint requires urgent action to rule out life-threatening disease. Third, fourth, sixth cranial nerve palsies can all be caused by tumors, although some are more common than others. The third cranial nerve, the oculomotor, innervates the superior, inferior, medial recti muscles, along with the inferior oblique, as well as doing the parasympathetic pupillary fibers and the levator. The fourth cranial nerve is just the trochlea, or called the trochlea, and innervates the superior oblique muscle. And the sixth cranial nerve, the abducens, innervates the lateral rectus muscle. So when we look at what damage to these cranial nerves looks like, we can see that the third may include ptosis due to the effects on the levator, maybe pupil involvement because of that parasympathetic fibers. And as a general rule, pupil involvement is more likely in a compressive lesion, something directly pressing on that third nerve. But as with all things, it isn't foolproof. The third can be damaged by a number of mechanisms, although tumors are less common, it is still a concern. Fourth cranial nerve palsy may result in a head tilt, and that's commonly caused by head trauma, although again, other causes are possible. Sixth cranial nerve, perhaps the biggest red flag from a tumor perspective, the path of the sixth cranial nerve over the petrous tip means that if intracranial pressure rises, we can see a new esotropia. And if you see a potential 6th cranial nerve palsy with any other signs, particularly a swollen disc, I'd say that's a double red flag. So just to help visualize what each presentation of cranial nerve palsies looks like, we've created this graphic. And these are all right-sided palsies, and they would be opposite, obviously, if they were left-sided. We can see that in the primary position, a 3rd cranial nerve has an eye that is down and out, most likely with ptosis, and potentially with some pupil involvement. In the 4th, the eye is up and slightly out. And in the 6th, we've got an eye that's turned in. And by getting the patient to look left or right, we can see that the angle of the deviation changes quite significantly. So back to the cases, and then we'll take a few questions. So if we can consider the revision that we've just done, are there any red flags on case 1? And the answer is yes. We have a vague presentation of headaches, but the visual field loss is the real red flag here. It's the same side of the visual field, and we know that could indicate a lesion within the brain. So we have a congruous, homonymous lesion, and in truth, it never really fitted with an artifact. This either needed repeating, in which case if it wasn't there and it was an artifact, great, or it needed referral. Case 2. So the red flag here is the headaches and sickness, and there's probably a false reassurance that the GP has this in hand, and maybe they do, but the record doesn't really support that. There isn't a note of extended Lofsy type questions or targeted questions. They might have been asked, but they weren't recorded, and that makes defending this really difficult. Also, the CD ratio is recorded as flat with no cup. And there aren't any additional notes around this. There isn't a note about what the disc margins are like or anything. It could be actually that really flat cup was a little bit of disc swelling, a little bit of early papilloedema. Now, case 3, this one has a couple of red flags. We've got the initial diplopia and an esophoria, and that is a red flag, but it might arguably be a little bit too subtle, especially with that previous head injury. So I don't think many people would be overly critical at this point. But once they come back with worsening BV problems, worsening problems generally, alarm bells should be ringing or red flags should be being waved. The sudden ESO is consistent with a 6th nerve palsy, which, as we know, could be a sign of raised intracranial pressure. So I'm going to give you some quick top tips, and then we're going to take some questions. So first of all, rare things are rare. They're exactly that, but they do exist and they could be sat in your chair. If you ask the patient something in a history, make sure you write it down. If it's not written down, how do we know? How can we prove it afterwards? Sometimes decisions are difficult. We've seen how hard some of those OCTs can be to sort of to discern, or the images can be to discern. Sometimes you can only answer them with additional tests, and they're not necessarily found in optometric practice. Formal advice and guidance can be really useful if you have a clear audit trail, and as we move forwards, I hope we're going to see more and more of that. But you need to know the advice you're getting you're receiving can be relied upon. So forums are great for case discussion after the event, but using them to help group diagnose a patient can be risky because you might not be appraised of the information, and the person may not be as expert as you think they are. They might be just having picked up something I've just talked about and then saying, oh, well, the chap from the AOP said that if you see this, then whatever. So you need to be careful around that. Balance your risk tolerance around the risk to the patient. I don't want to encourage you to over-refer, but if you've done all you can or you're still concerned, take appropriate action. When this goes wrong, it really does have big repercussions for the patient and potentially for you as well. And look at the big picture. Each piece of information in isolation may not help you very much, but if you step back and put them all together, sometimes it's a lot easier, and often it's a lot easier to work out what's going on. Thank you very much for listening, and we will happily take some questions.
Thank you, Aoife and Peter. That was brilliant and terrifying in equal measure, I would say. So let's have a look at some of the questions that have come in. First question from Imran is, are brain tumours on the rise? Now, I haven't got context to that other than the question itself. So I'm not sure whether Imran is referring to number of cases seen by the AOP or an increase in brain tumours themselves.
So I don't think there's any evidence that the incidence of brain tumours is particularly rising in the UK. So I don't think there are lots more brain tumours out there particularly. But I think Aoife, I think you said in your talk about that we are seeing more of those cases. So I think maybe people are becoming more aware of them. Do you think that's fair?
I think that's fair, and I mean, maybe a point for you, Peter, is in relation to equipment. It's equipment that we're seeing in practice now, and making it more, more prevalent for the possibility to diagnose.
Yeah, I think that's probably fair. I think, and obviously not just us at the hospitals and all sorts. So maybe things are being found that previously weren't. So I think that's perfectly reasonable.
Okay. Paul just has a question about case 3, which was in relation to the head injury. So how long ago was the head injury? I think it was a year prior to, wasn't it? But presumably CT MRI imaging was done at that time?
Well, and this comes back to sort of what information you've got on false reassurance, I think. So again, hopefully as we get joined up to the hospital systems more and we can see what's going on, we might be able to access that information and we might have a definitive answer. In this case, and this is one that's from a few years ago, probably about 5 or 6 years ago, I think, we don't have that information. We don't know whether or not that was done, or at least the optometrist didn't have that information at that point. So they were sort of putting 2 and 2 together, and unfortunately got to 5 and not 4 in this case.
Okay. A couple of questions here that are linked, really. So is the presence or absence of spontaneous venous pulsation or inducible VP still considered useful in early disc changes?
I think so. I think particularly with venous pulsation, I think it's one of those things that if you don't see it, we don't worry about it. But if you see it, it does help, because it helps to prove that the disc isn't swollen. So I think there is still some use for that, absolutely.
And next question relates to headaches. So isn't it common to get nausea and vomiting with migraines? So I guess, how do you differentiate that from headaches that might be due to papilloedema?
It is. So migraines are generally quite short-lived and so they shouldn't last overly long is the first thing. So the period of the headache should be relatively short. But also, once they're medicated, actually, then they shouldn't particularly be getting those headaches. So something out of the ordinary. You need that assurance. And I think writing to the GP, finding out exactly what's going on, can help to provide that. I think in the case we're talking about, case 2, I think it was, wasn't it? So if the optometrist had written to the GP, and lots of people on the poll said, I'd have written to the GP, and they get a letter back saying, well, I've sent them to the hospital, they've had all the scans and everything's normal, I think you can say, well, fair enough. But without that assurance, without that extra information, then you just didn't know. So you should have been thinking about it. Well, what's going on here? I've got a patient with these headaches, and they're still being poorly, and they're being medicated. This doesn't feel quite right. And there was a red flag there with hindsight.
Okay. I think we've got time for one more question, which is actually a cluster of several on visual fields. So I'll give you a flavour of these different queries. So some practices I've worked in recently aren't doing fields due to COVID. What should we do in this case? Someone else has asked, do we have to do visual fields on every patient? And final part of that question, is there a particular fields program that you would recommend for headache sufferers?
Wow, okay, so that's a good one. So let's start with COVID. So COVID, routine fields have been suspended. So I think the opportunistic, I found a visual field loss when there was nothing else at all wrong. We've probably not been doing those. Fair enough. You will miss a few things that you might have found by pure chance. Those are in a separate category. The ones where they presented with something that sounded abnormal, or you found other abnormal signs, you could have still been doing fields on those for pretty much the whole period. So those should still be being done. They're needs driven. That would be okay. And the third part was what field loss. Largely anything. You're looking for gross defects. You're not necessarily looking for very subtle defects like we would with glaucoma. So whereas you'd use something to pick up very early changes in glaucoma, hemifield loss, quadrantinopias, things like that, you should find those on pretty much any sort of suprathreshold test.
Thank you. So I think it's a good place to wrap up. If anyone has any further questions about this webinar, then please email events@aop.org.uk. It's worthwhile letting you know that the recordings from all of our webinars today will be available on demand, although CET won't be available for those. We've got another 6 sessions running through the day today. So next one will start in 15 minutes. So got another 6 interactive CET points on offer. So hopefully you've got time to grab a cuppa, and then we'll see you at 10:45, which will be a session about detecting peripheral retinal abnormalities. So we'll see you all in a while. Thank you.